if it's any consolation, thank you for that introduction, but if it's any consolation, my wife has said that if ever she was to die, she expects me to be walking around the house with the kids saying, "Who's the lady in the photo with us?" So thank you very much for inviting me here today. I'll try to talk some specifics about pharmacological therapy of POTS, and in particular about the two main drugs that I use, which are Midodrine and Fludrocortisone, and a little bit about ababradine and beta blockers, but the lesser on the beta blockers, because I think most people here will know about using them pretty well. I don't have any disclosures apart from these. I didn't mention that I make money in my private practice, but of course I don't charge for that. POTS this is what I'm going to go through today. A bit of background about POTS, how I see it, the treatment protocol, discussion about pathophysiology and mechanisms, and then finally finishing off with the specifics on the drugs. There's just a bit of a case that I'll throw up there. It'll be very quick. As everyone scans through it, they'll see straight away it's a typical one of the patients we've been talking about today. 15-year-old comes with a mum, lots of complaints, a lot of blood pressure complaints, progressively dropping out of function, leaving school, leaving sport, leaving socialisation, a number of practitioners involved, some measurements of blood pressure, being told it's normal, and these are the questions that I would typically run through with her to see whether she has a problem with blood pressure. And I won't really go through those except to mention that I'll talk about the situations, postural change, prolonged upright posture, ask a few questions about cognition, salt and water intake, anxiety. And of course, at the end of it, it's pretty obvious that she needs some treatment. This is the paper that many people will be familiar with. It's the paper from New England Journal back about 20 years ago that got I guess where POTS became a thing, got some notoriety. And in that paper in table 2, there was published a list of complaints that are seen with POTS, and you can see them down the bottom there. There's just a few of them. I'm pointing to the panel on your left. That's what I'll keep pointing to today. And there's a few down there. And the big problem with this paper is it didn't really mention all of them. This is the list that I use. I use just some crappy little acronym to try and remember it. And it's there. Everyone knows we've gone through this multiple times today. This is a really big disease. Really big diseases get really big treatments. And when a patient comes to see me, by the time they see me or many of the other people in this room, those patients will have been around the track and had treatments for many other conditions. So it's not terribly surprising to see that they might be treated for their pain with various types of analgesics. They might be on several from that. They might be on something for fatigue. Their blood pressure we'll talk about in a moment, but their guts will be treated, and that's an abbreviated list. Wouldn't be a surprising again if they had 2 or more medications for their migraines, several for their mast cell activation, and then sleep might be a bunch of others, and finally they might even be on some hormone suppression for their cycle, something for their bladder function, and potentially anticholinergics. It's not terribly surprising to see these patients that are on 10, 15 different medications when they arrive. Added into that is that they have a whole lot of other factors that make them complicated. It presents at a time of particularly important developmental levels, so adolescence. These patients are much more difficult than a 70-year-old who's got one problem. It's confounded by the association with autism spectrum disorder and ADHD. So not only do they have a lot of difficult medical problems, but there are some behavioural issues in there magnifying it. Then on top of that, there's the inevitable psychological consequences. There are social issues, particularly regarding schooling and financial support. These are people who are at the start of their journey onto welfare, and so they might need that. And then finally, there is the issue itself, the cardiovascular disease, which suffers from the problem of being something that's very poorly understood but quite understandable. Or in other words, patients need a lot of education to learn about it. What this adds up to is the fact that these patients, a consultation with one of these patients, is about as challenging as any patient in medicine. And I say that as the former director of general medicine at the Austin Hospital. So general medicine is where the most complex of the complex go. My patients, the typical patients I see, are much harder than any patient I saw in general medicine. In fact, I don't think there's much, have any real embarrassment about saying they're more complex than any patient in medicine. And if you think about the complex patients in medicine, you might think about a patient with a liver transplant. Well, you know, they have 5 or 6 different concomitant issues, but that'll be it. There will be 5 or 6 medical issues, and there won't be the psychosocial issues, there won't be the development problems. Same thing applies with a difficult hematological patient. So what we're talking about here, although it's a disease that never kills anybody, it is actually the most complex condition in medicine. The knowledge base for it is pitiful. I think it was embryonic was the word we heard before. For high blood pressure, there's 28 separate journals with hypertension in their title. There are, of course, 0 with hypotension. If we do a Medline search for these various terms, you'll see that POTS and orthostatic intolerance together get about 700 or 800 mentions. Compare that to endometriosis, which you'll see in the ABC website every second day. Someone will be saying, endometriosis, everyone ignores us, everyone hates us, endometriosis. If you've got POTS, you don't even get on the Mercury News. All right, the database now. We're onto the database. This is all sort of fluff. It's not really helping to get the syntax, but it's sort of necessary to understand why the syntax are so blunt. The data is really poor. It's limited in quality. The definition of POTS is a really poor definition. It's a heart rate that goes faster when you go from lying to standing. Yet, as we've heard today, the problem seems to be, or at least a part of the problem seems to be, that there's a problem with getting blood from the belly back up to the heart. It's a bit like describing a lacerated finger as erythrocytes on cuticle disease. It's the downstream consequence. The study populations in the trials are very poorly defined. The definition of the diagnostic definition is variable. The definitions are often exclusive. They say, yes, this is a study of POTS, but we exclude patients who faint. Or studies of patients who faint would exclude patients with POTS. The trials are usually undifferentiated with regard to disease severity. That is, they'll include anybody. So it's very difficult to extrapolate from the mild patient who's got a few symptoms and is still functioning well to the patient who's in a wheelchair. They don't make allowance for the comorbidities. The age variation is quite large in the trials, making it difficult to extrapolate from a trial to the patient sitting in front of you. And of course, there's I won't talk about gender. There's just trouble there, isn't there? Okay, the trials are very small in the main. There are very few large trials, and they're very limited in duration. Like we're talking about 4-6 weeks for most of them. Very few trials will go for a year. The endpoints finally are heterogeneous. There's no agreed endpoint which most of the trials agree to, and they're almost all surrogate markers. They're markers like questionnaires of function and well-being, but they have very little markers on actual outcomes expressing improvements in function or mortality benefits. Of course, the mortality is never going to be a real major issue. So, at the end of that, At the end of that, what we're left with this. We're left with a condition that's incredibly complex, poorly defined, hard to measure, the pathophysiology is still not understood, and it's frequently comorbid. Add into that a database that's immature and imprecise, we're left with our decision-making about treatments based upon these things. We can only use literature as a rough guide, and the decisions about therapy are really made by knowing, number one, pharmacotherapy, and matching that to our best guess about the pathophysiology, and then taking extrapolations from similar conditions which have similar sorts of presentations. And in this situation, most of the extrapolation comes from the syncope field where the data is more robust. So, I'm now going to talk about a treatment protocol, and this is the sort of clinical message that I want to put up first. And this is my treatment protocol. I think it's probably pretty similar to most other people's, but there will be variations. I don't want to dismiss education, but I will dismiss education. Visit 1, I will advise a patient, so we take a patient like Rose, who we saw before, she clearly needs pharmacological therapy. There's no point really sending her away and saying, tend to your lifestyle, come back and see me in 3 months. That nothing's much will be achieved from that. So for her, at the first visit, I'll advise on dietary salt, and I'll also prescribe these two medications. The first will be a dose of Fludrocortisone starting at 0.1 milligram. I'll ask her to increase the dose to 0.2 milligrams after 1 week. After that, if that fails, I'll ask her to add the Midodrine. And the Midodrine I'll start at 5 milligrams in the morning and lunch for the first 4 days, then on to 10 milligrams morning and lunch for the next 4 days, and then I go to 15 milligrams in morning and lunch for the next 4 days. I think that next step there, 15 milligrams, is probably more than most people would do. And then I ask her to come back in 6 weeks. If she was one of the patients who is intolerant or insensitive or resistant to the poisons of factory-made pharmaceuticals, or she had tried these medications in the past and they'd been problematic, she may go down the medication, what I call the medication intolerance route, which is the complementary medicines. I'll come back and talk about them later. Licorice root, which is the analogue of Fludrocortisone, and butcher's broom, which is just, I think, a bunch of leaves in a bottle, but is meant to act a bit like this. She comes back in 6 weeks, and then it's all options are on. So I think for the purpose of today's talk, I'm really going to focus on this step up here, because by the time patients come back to this step down here, they have, I suspect they're probably at the level where people are going to be seeking external help. So let's talk about them. So we're now going to talk about but before I talk about them, I want to just try and categorise them and work out why and when I use them. So you've seen this slide before. The pathophysiological mechanisms are twofold. Number one, it's getting blood back to the heart. Number two, it's having the autonomic nervous system malfunction in some way, so-called dysautonomia. The factors that contribute to blood not coming back to the heart, we've gone through them already. The stretchy blood vessels, hypovolemia, whatever. We don't really need to consider those factors because I don't think they impact on the treatment, the pharmacological treatment that we're talking about today. Okay, number one, we'll just talk about venous return and why it's so important. And for this, we'll go to the Starling curve. Now, the Starling curve is actually the Frank-Starling curve, and it was named after these two punters, Otto Frank and Frank Starling, who were turn-of-the-century physiological investigators. Otto was the smart one. Otto was the first one. Frank was the smart one. And Frank was the smart one because he had a name that was the same as the surname of this fellow. And so originally the curve was called the Frank-Starling curve, but everyone thought, oh, no, we don't have the Bob Cushing disease, so we're going to go call the Starling curve. So Frank's been left with the curve. Now, Frank also got a curve named after him in another way, in that demonstrates his brilliance, in that he got a curve named after him for demonstrating the fact that if blood doesn't come back to the heart doesn't pump blood. It's fundamentally not a difficult concept. Blood, if the heart does not have blood to pump, it doesn't pump blood. And when blood comes back to the heart pumps that blood. So the amount of blood coming out of the heart is equal to the blood coming back to the heart. And it's as simple as that. And it must be, because the heart must pump the blood that gets back to it. Because what else could it do with it? It can't make it go to Uranus. It has to, as in the planet, it has to pump the blood. Otherwise it backs up. So it's very simple. The Starling curve is a very simple demonstration of a pump that pumps efficiently. So the prime determinant of your cardiac output is the amount of blood that gets back to the heart. That's all. Okay, so once the blood gets back to the heart, then it's got to go to the brain. And going to the brain is where, I'll just talk about this. I don't know why I'll talk about this. Oh yeah, this is number two, why dysautonomia is important. Now, the blood's now got to go back to the brain. Now, here's the issue. If there's not enough blood getting to the brain, then the autonomic nervous systems are going to react in a very bad way. That's one possibility. Another possibility is you've got a dodgy autonomic nervous system that malfires, that malfunctions, and that's a primary issue. I don't think the data is robust enough for us to say which one's which. Either way, activation of that autonomic nervous system is problematic, and that's shown by this 24-hour blood pressure heart rate monitor from one of my patients. Now what this is, I'll just take you through the panels because it's sort of interesting. Down the bottom is the activity. It's got a little movement sensor. So you can see here's the patient, all these blue bars is where the patient's moving. Here is the heart rate, here is the blood pressure. So the red lines up here are the blood pressure. And as you can see, the patient's got a blood pressure that's pretty lowish, sort of young woman low. The heart rate down here is profound. So every time this patient does anything upright, she goes from a resting heart rate of, 70-ish, up to about 150, 160. Or in other words, every time she's upright, she's got a heart trying to throw itself onto the floor, she's got thoughts flying through her brain about how she wants to kill her husband, she's got the shakes, she's sweating, she's thinking, we all know what the story is. So this is the second component of the postural response. So the first one is not getting blood back to the heart. The second one is trying to control the autonomic response of not getting blood back to the heart. We shall press on. So now trying to match those drugs with physiology. I didn't mean to have all those little jumps in there. So what we're going to do is now talk about medications that, number one, affect venous return, and then number two, that affect the autonomic nervous system. I may briefly touch on this, that's disease-modifying agents in the end. So medications that affect drug getting back to the heart, we've got the big ones: sodium supplementation, Fludrocortisone, licorice root we talked about a moment ago, Midodrine. Midodrine is a alpha-adrenergic agonist, one of the vasoconstrictors. It's probably a venous constrictor. That's probably where it does most of its work. So it's probably getting blood back to the heart also, like the Fludrocortisone. So we put it in this column here. And then there are a couple of others which we won't mention. Then later on, will briefly glance over these two here. So let's begin with talking about salt. Salt. So salt is a drug. There's no question salt's a drug. And this is the dietary advice I give. So this is clinical message number 2. I want patients to take, and this is what the guidelines say, the recommendations, which are not really based on anything, or I shouldn't say not really based on anything, not based on much, to take 10 grams additional salt per day. How do you take that salt? The answer is roughly 2 extra teaspoons of salt in addition to what you're currently consuming over your meals. You mention that to a patient, mention that to Rose with the mother, Roseanne, sitting next to her, and Roseanne looks like she's asked you to eat a baby. You want my daughter to take salt? And then you say, I want you to put on some weight. So go to McDonald's on the way home and the kid's fist pumping and Roseanne is just sending daggers at you. And so she should. We've been well trained to have a reduction in dietary salt. So what am I going to do with this dietary salt? Am I going to kill the patient? And this is the first big debate that I have with the patients. Up to this stage, they're putty in my hands. And then I throw salt at them and suddenly we're back to anger again. So let's talk about what salt means. So down here, what this graph shows is a number of countries through the world and their salt consumption. So the average Australian dietary salt intake in Australia at the moment is about 9 grams a day, 8 or 9 grams, around that sort of bit. New Zealand just a little bit less than us. China right up the top. Japan I think is quite up there too. Japan, where people live the longest in the world. Okay, so that's the typical dietary salt intake per day. So we're asking her to double what she might already be taking, but because she's a she's a young, health-conscious female, and she's got a health-conscious mother, they're probably consuming quite a lot less salt than already. In fact, I remember one patient saying to me, so the first thing I did was I got rid of all the bad stuff we ate. And we just ate green, because they didn't have a molecule of sodium chloride in a month. This is salt consumption compared to the health guidelines. So here we have a number of countries. There's China again, there's the US, there's where we are. So same data as the previous slide. But now what I'm going to add in is the guideline recommendations. The American Heart Association, they're pretty mean. They don't allow you to have much salt at all. The Europeans, as you would expect, much more lax. And the British are in there, for once in their life, the British are siding with the Europeans. But you can see that's pretty low. That's about 4 grams of sodium chloride per day. Oh, sorry, it's 4 grams here, 6 grams there of sodium chloride per day. So we're going quite a long way above what the health authorities are saying. Or in other words, we're trying to murder the child. How much salt? This is a bag of sodium chloride, the typical bag that you see hang up on the drip on the wall at work, on the peg at work. The typical recipe for diet for fluid requirements is 2 sweet, 1 salt. So for each day, the patient needs 3 litres of saline. Your typical patient needs 3 litres of fluid. 2 of those are the sweet, the sugar, the dextrose, and 1 is a salt. The salt is this one, 0.9%. 0.9% means 0.9% of a litre is 9 grams. So it's 9 grams of sodium chloride in a bag of saline. So we're asking patients to take an extra one of those. Salt tablets. Salt tablets have 600 milligrams of sodium chloride in them. So the mathematicians in here will have quickly worked out we're talking here about taking 16 additional salt tablets per day. Expensive and nauseating. Okay, so that we've decided to kill this child. Let's talk about how effectively, how well the child's going to be before she dies. There is not a huge amount of information from this, but these are the results from meta-analysis of various studies done that was published about a year ago. And in the forest plot on the left, we've got the effect of salt in patients who have vasovagal syncope. And what this measurement down the bottom is the number of minutes, extra minutes that they achieved by having dietary salt added in a tilt test. So on average, they got another 10 minutes before they started to feel faint with adding salt. And how much salt was that? The range was 1.5 grams to 17.5 grams. Over here, we have a series of studies that some of which are POTS patients, some of which are vasovagal syncope patients, and they've been lumped together. And again, it's that same salt range, although we did start a little bit lower. And in this situation, the black bars are the patients who are reporting a improvement in symptoms. And you can see with, I guess you sort of eyeball it, roughly about half the patients in these trials with these varying amounts of salt have reported an improvement in symptoms as pre-specified in those trials. So salt, about 50% of people who consume salt will report an improvement in symptoms, roughly. Are we really going to kill this child? Well, let's have a look at the safety of salt. This trial, what this data here is a very simple something that everybody here knows, which is that as you increase your salt consumption down the bottom, you get a rise in systolic or diastolic blood pressure. Salt makes your blood pressure go up. Good, that's what we want it to do. High blood pressure kills people, so ergo, salt must kill people. And in fact, that's what the Americans say. Excessive salt consumption independently associated with blah, blah, bad. This study came out in 2016. It was an enormously controversial study, and the Americans actually, a lot of resistance came from across the Atlantic, back at the publishers, the British publishers who put this together. And this is a study of 133,000 people. A number of trials, the salt measurement was, their salt intake was measured by a spot urine sodium output. It's a bit of a dodgy measurement, perhaps, that's what a lot of the argument was. But it showed something that there's this dirty little secret of salt and cardiovascular disease, which is, sure, higher levels of salt are associated with higher levels of cardiovascular disease, but so are lower levels. There's this U-shaped relationship. What these investigators did is they teased this out a little bit more, and what they showed is that they broke it down into patients who have high blood pressure and those who don't have high blood pressure. The blue line here is the final data, and sure, it looks like increasing salt in these hypertensive patients means more cardiovascular disease. But the line's flat in people who don't have high blood pressure. Or in other words, if you have normal blood pressure or low blood pressure, there's not great evidence that salt's going to do you any harm, and that in fact is backed up by the European guidelines. So this is where the rubber hits the road and you have to be very confident in what you're saying. The Europeans say the effect of reduced salt on cardiovascular disease remains unclear. There's no evidence reducing salt from high to moderate causes harm, but you notice they don't say there's no evidence of going from moderate to low. They specifically avoid saying that because the data doesn't allow them to say that. So I think that when a patient says, are you going to kill me with your salt? There's your answers. Fludrocortisone, drug number 2. I think I've got 5 minutes left and I'm going to do it. Fludrocortisone dose 0.1 to 0.2. Efficacy, we'll cover this in a moment. Probably effective. Certainly probably effective for syncope, but not proven. Likely effective for POTS, and it might work with Midodrine as well. This is the side effect that's not very well known. About 1 in 50 patients with fludrocortisone will come back reporting some sort of emotional problem, sort of depression. I hate that medication. It just makes me feel terrible. It comes on very early in the course of treatment, goes away very early. If patients are pre-warned about it, they can just stop the medication and it saves them from that thing of coming back and saying, you tried to kill me. You didn't get me with the salt, but you tried with the fludrocortisone. Question, should fludrocortisone be taken with Midodrine, and does fludrocortisone have corticosteroid properties? Should we stop it for vaccination? This trial here was done from circulation 1966, and what this is a trial of is patients who had their forearm vascular resistance measured with norepinephrine. So increasing doses of adrenaline along here, and as you would expect, the resistance in the blood vessels goes up. This is the solid black line is pre-treatment. The dashed line here is when patients have fludrocortisone. Or in other words, giving fludrocortisone makes adrenaline work more effectively. So that's the rationale for adding the fludrocortisone and the Midodrine. This is Australian product information. Patients should not be vaccinated against smallpox while on corticosteroid therapy. This is from the Florinef, the fludrocortisone paper, PI, and immunisation procedures should not be undertaken on corticosteroids. Is fludrocortisone a corticosteroid? We now have to go back to about 2004 for this one. This is a whole bunch of steroids ranked according to their efficacy on the glucocorticoid, the cortisone, the prednisolone receptor. And there's fludrocortisone down the bottom. Yeah, it does it. It jumps on. It saturates the receptor with this 1.9 times 10 to the 9th. But when we look at the mineralocorticoid, the real receptor it works on, concentrations are 400 times lower than the dose at which it hits the glucocorticoid, where it gives the prednisolone effect. That's when you pick up the mineralocorticoid effect. So the salt-retaining properties of fludrocortisone come in very, very low. This is not a glucocorticoid drug. There is probably no reason to stop it with immunisation. Does it work? There's been, I will say, this is the one trial. This is what's called the Post-2 trial of fludrocortisone and vasovagal syncope, and in this trial, the p-value was 0.069. It just fell short. But syncope in the patients receiving therapy, fludrocortisone at a dose of 0.1 to 0.2 milligrams, after 12 months was 60.5 to 44. So roughly a 25% reduction in syncope, probably. That's fludrocortisone. Let's talk about Midodrine. Midodrine 5 to 10 milligrams, efficacy. This is the same drug as Sudafed. This is Sudafed PE. Go down to the supermarket, you can get it off the shelf. It'll actually end up costing you more. You have to buy more tablets. It doesn't cross the blood-brain barrier. It shouldn't make you hyper, so to speak. This is not dexamphetamine. Probably effective for syncope, likely effective for POTS. Side effects. Major one is piloerection. It makes your hair stand on end, just like adrenaline does. So patients get tingling down their head and their scalp and all down their back. It feels like someone's walking my grave all day, doctor. It's the opposite of prazosin. Prazosin's that lovely drug for helping old men with urinary retention. Give them Midodrine and into urinary retention they'll go. It lasts for about 3 or 4 hours. I can take 3/4 of a tablet and then I'm busting for a pee. I can't take anything more than that. Does Midodrine cause supine hypertension? It says on the box, the black box warning, This drug causes supine hypertension, and this is about my last data slide. This is what happens to people who have supine hypertension. That is, they lie down, they're on Midodrine, and their blood pressure shoots through the roof. Does that happen to young people? We'll answer that in a moment. Does it happen to older people? Absolutely. This is a patient with autonomic neuropathy. So this is an older patient. You can see that her blood pressure, she's very proud of this record. She wanted her name on here, she said. And she wanted to show what happens to her at night. So here she lies down and her pressure goes up and up and up and up and up until in the morning when she gets out of bed, and you can see she lies down, she gets out of bed, measures blood pressure, and her blood pressure drops by about 80 millimetres mercury. This is dead autonomics. It's the opposite of patients with POTS. This patient has no ability to regulate her blood pressure. It's controlled by her posture. The patient with POTS has a beautiful autonomic nervous system. She lies down, she can control her blood pressure. In my clinic at the Austin, we measure blood pressure lying and standing on every patient, every visit, every time. I've done tens of thousands. I've seen this sort of picture, supine hypertension, a million times in my patients with autonomic neuropathy. I have never, ever, ever seen it in a young POTS patient. So, do not worry about lying down if you're on Midodrine. Treatment failures. Oh, I've got to finish. Oh, I don't. Oh, settle in. Okay, treatment failures. When treatment fails, sometimes patients can't tolerate fludrocortisone. My alternative then, and this is a pretty good alternative, is licorice root. Licorice root was discovered by Theophrastus, good old Theophrastus, and he noticed that the Scythians were marching across the desert and waging war very effectively on their hometown, and apparently they were eating licorice all the way so they didn't have to drink and so they could get across the desert. He also said we die just when we are beginning to live, which when I read it, I realised that's the line that the parent of adolescent children says. Pliny the Elder, who made this comment about it makes varicose veins go flat. Oh, yeah, it makes varicose veins go flat. And he was also said, fortune favours the bold steer to where the Pompeianus is, otherwise known as Pompeii, where his mate was trying to escape a burning volcano. They were the last recorded words of Pliny the Elder. It works in much the same way as fludrocortisone. It probably is exactly the same drug. Has some effects has some anti-androgenic type effects also. So it has corticosteroids or mineralocorticoid type effects, and there is some data that says it will increase smooth muscle tension in blood vessels extracted from a body. So there's a little bit of data that works for it. What's the dose? I learned from Murray Elder. He said, I just use 2 caps. I kept on using 2 caps. Does it work? Sometimes it seems to. Licorice root, it's not licorice. So you can't buy the candy. That's not it. It's licorice root, which is this horrible, salty, anaesthetic thing that comes from Holland. It's called Dutch licorice. That's the other name for it. It's disgusting. If it doesn't taste disgusting, it's not worth it. Ruscus acolytus, which is butcher's broom, is a medication. In fact, I think I was showing the butcher's broom. That was that slide there is of the butcher's broom. That's the butcher's broom data. This is the butcher's broom data showing that it does have some effects, I think. Pliny the Elder still saying the same things he said before. There's a little bit of data that says this stimulates release of noradrenaline, activates alpha-1 adrenergic 2 receptors. It's got no described side effects because no one's ever bothered to write them down. Does it work? There is no documented evidence of it. If a patient is really keen on something complementary, I mention this for full disclosure. I certainly never advocate it. I'm going to finish with this last slide about avabradine. Quick mention about avabradine. I hate avabradine. It's a drug that has one side effect, one action, that is it makes the heart rate go slower. It has one side effect, it gives you scintillations, little things that come, vision, and it doesn't work. I think it's disgusting. Until this paper was published last year, which showed, in fact, it does work. And the reason it doesn't work for me is because it was my third drug. It was the drug I always used in the people who didn't respond to the first two. So I was up against a hiding before I even used it. This is a trial. I won't mention the details. Typical POTS type patients, 5 to 7.5 milligrams. So it comes in two strengths, the low strength or the high strength, twice a day. Placebo crossover, didn't go very long, mainly women, mainly young, and they had improvement in their physical function, in their social function. Their quality of life improved. These are questionnaire based. They didn't get up and go back to work. We don't know much more than that. But it seems like it works. It seems like O'Callaghan was wrong yet again. I won't talk about propranolol. Instead, I'll just talk, the last thing I mentioned, immunosuppression. Should one take some immunosuppressants? Here's a lovely trial published this year, cyclophosphamide, the biggest, dirtiest, nastiest drug known to man to treat chronic fatigue syndrome. And it worked. It was done, I think, I've forgotten where it was done, but it had a nice little result. 55% of patients responded over 12 months. Chronic fatigue syndrome, POTS, sort of similar sorts of crossover. Maybe we should use this in POTS patients. Maybe we should give them all cyclophosphamide. These guys did. Why laugh? They did it. Well, the big problem about this trial is that it was uncontrolled. It was a phase 2, open-ended. Maybe they'll get better. Who knows what. The trial that's probably more germane is this one, the use of rituximab, another big dirty drug that kills all your B cells. Not as nasty as cyclophosphamide. That kills your Bs, your Ts, your As, your Bs, and whatever. It kills the alphabet. This one is much more specific, but it's the one that treats lymphomas really effectively. It's revolutionised it, but a dose of this will wipe out your B cells, your antibody-producing cells, for the next 6 months. A trial was done in chronic fatigue, ME/CSF, infliximab, 12 months, outcomes identical. Or in other words, when the trial was done properly, there was no benefit. So at this stage, I don't hold out much hope of immunosuppression for helping POTS either. There's my protocol. Quick summary points. The database, it's limited. You just have to work on what you can work out rather than what the guidelines actually, what the didactic evidence says. You certainly can produce symptomatic relief. Does it produce a long-term functional benefit? I think it probably does in some, but there's no evidence that it does it. Is it safe? I think the data says that all these drugs are pretty safe. And as I mentioned, the long-term functional efficacy is not known. So thank you very much for your attention, and I'll just leave you this quote from an American journalist that probably sums up the state of knowledge as we stand. Thanks very much.